ask a question, you would press star 1. Please record your first and last name. If you need to withdraw your question, you would press star 2. Today's call is being recorded. If there are any objections, you may disconnect now, and I will turn the call over to Marlene Peters. Thank you. You may begin.
Hello, good afternoon, and welcome to today's webinar hosted by the Department of Health and Human Services Sickle Cell Disease Stakeholder Engagement Workgroup. I am Marlene Peters Lawrence with the National Heart, Lung, and Blood Institute at the NIH. I would like to also introduce Ms. Giovanni Spinner, who is the Senior Public Health Advisor at the FDA. We are the Stakeholder Workgroup co-chairs and moderators for today's webinar.
Thank you, Marlene. Our group is just over a year old, and our vision is to help improve the health and well-being of people living with sickle cell disease. And we do this by building a linkage between the sickle cell community and the federal government. Our mission is to connect with stakeholders and disseminate credible information while also continuing to raise awareness about the disease. The purpose of today's webinar is to learn more about the importance of utilizing the primary care setting to manage medical care for individuals living with sickle cell disease.
So today you will hear from a distinguished panel of speakers as they share their perspectives on the importance of connecting individuals living with sickle cell disease to primary care physicians and the strategies being used to improve connected care. So before we get started with the presentations, I have a few housekeeping items to go over. As a reminder, the webinar will be recorded. All the participants' lines are automatically muted. After the presentations, we will take questions from the audience. We will try to answer as many questions as possible, so please type them into the Q&A box below. So our first speaker is Dr. Julie Cantor. She is a lifespan hematologist specializing in sickle cell disease at the University of Alabama at Birmingham. She will present the physician's perspective on primary care in sickle cell population.
Hello and good afternoon. Thank you so much for having me today and hosting me as part of this important initiative. Sorry, having some mouse issues. So I'm going to talk about where primary care fits into sickle cell disease management. I do have multiple disclosures. It's important to note that I work very hard to ensure that individuals with sickle cell disease have new therapeutic options and offer my consultative services in that way. None of what I'm going to talk about today will be relevant to any of my disclosures. The objectives of our conversation today are to identify challenges to care for adults living with sickle cell disease specific to the United States. We're going to look at some models of care for sickle cell disease, and then really talk about co-management in sickle cell disease, what that means, and exactly how we improve co-management with primary care. As many people know, sickle cell disease is a rare disease that still limits life expectancy through chronic complications, and that's despite significant improvements in childhood survival. At the individual level, it is often about where someone lives. Healthcare opportunities and insurance are state-based and actually can be entirely based on zip code alone. Insurance may be available, but that doesn't guarantee access to appropriate care. And best care may equilibrate to those individuals that have the most knowledge or the best advocates. When we look overall at where the individuals with sickle cell disease are living, you can see the population is overcoming our current workforce. We know there are at least 100,000 individuals with sickle cell disease living in the United States. I would hypothesize even more than that. The highest concentrations are in the South, Southeast, and California. We have great data out of the West Coast, thanks to the CDC Sickle Cell Data Capture Project, which has specifically showed us that their life expectancy is actually below 40 years of age, compared to the national mean at about 42 to 47 years of age. We believe that much of this is because of a lack of access to knowledgeable providers. So when we think about providers, thanks to Dr. Smith and Dr. Lautenberg, they've kind of put into 4 different categories. So the first is the unengaged provider. That could be a primary care physician, but it may also be the hematologist-oncologist. This is the provider who may not want to necessarily feel comfortable or have interest in seeing individuals with sickle cell disease. We then have willing providers, again, a primary care or hematologist-oncologist. These are individuals willing to take these patients into their care, willing to learn to prescribe hydroxyurea and hopefully other disease-modifying therapies, but they may be a little bit more unfamiliar with the evidence or not up in the continuing medical education. And this provider will often work with or refer to sickle cell disease experts. There's a willing high-volume provider. This is someone who, like the above provider, is happy to see individuals living with sickle cell disease, but is more interested in continuing medical education to ensure that they are aware of evidence-based practices. They will care for more individuals affected by sickle cell disease, but still rely on experts as well. Finally, there's the sickle cell disease expert. This can also be a primary care physician who's received external and extra training in sickle cell disease management, or a hematologist-oncologist. They can accept and attract sickle cell disease patients into their actual patient panel with intention. This is somebody who wants to provide sickle cell disease specific care, often in an academic or sickle cell center. When we think about the complications in sickle cell disease, they are unfortunately throughout the entire body. As sickle cell is related to the blood, the complications go anywhere that blood and blood vessels do. As blood vessels are really the target organ of this disease, as well as inflammation and ongoing risk of infection, all of the areas fed by blood vessels can be affected. So the complications are widespread and really require co-management. However, all those complications in sickle cell disease, unfortunately, do not limit the ability to have other problems, other comorbidities, just like every other adult. These include diabetes, cancer, high blood pressure, coronary artery disease, gout, as well as primary care screening that's really important. Just because you have sickle cell disease, it doesn't mean you don't need a mammogram, and it certainly doesn't mean you don't need a colonoscopy, something for which we rely on primary care colleagues to help us with. When you think about an adult sickle cell center, we know that that offers better health outcomes for affected individuals, that the care coordination is improved throughout the medical system, whether it's vertical care or horizontal care. That means whether it's care between the outpatient and inpatient units or throughout the lifespan. And the goal is to always improve quality of life for individuals to achieve longer and better lifespans. It also helps to improve relationships between patients and healthcare personnel and improve financial outcomes for the institutions and health payers, third-party payers as well. So it's a win-win all the way around. Unfortunately, however, these sickle cell centers are not universally accessible to everyone. So what is a center? What defines a center? It's a thoughtful, team-based care approach to adults living with sickle cell disease. It's where we give consistent and comprehensive care. It is a center that has a true programmatic emphasis on sickle cell disease and that does coordinate sickle cell care. But it's important to note that a sickle cell center still needs the co-management of a primary care physician. And we're going to talk about different models of that. When we think about different care models or sickle cell center models, we've really divided them up. One is the comprehensive care clinic model. This is similar to the cancer clinic model or cancer center model. This is a standalone sickle cell comprehensive care clinic, but they don't offer primary care within their walls and instead rely on co-management from outside providers. There's an embedded adult sickle cell program, and there's also specialized sickle cell disease medical homes. All of these can serve as hub and spokes models of care, and I'm going to go through them a little bit more in detail. Again, the classic sickle cell disease comprehensive center provides excellent team-based sickle cell disease care with a dedicated clinical space and staff. It includes an infusion center and day hospital and is usually led by a sickle cell disease specialist. Within the center, they have access to all necessary subspecialists throughout the institution. Co-management is with external primary care, meaning it's with primary care providers who may be in the same city or the same institution, but not within the same center. This is often an urban model where the focus is not necessarily reaching an outside, more rural population, but they have a plan for primary care and co-management, and they usually include mental health within their care model. The Embedded Adult Sickle Cell Disease Center is sometimes used in smaller practices in partnership with a cancer care program or in partnership with a chronic care model where the center exists within another center. They share clinical space and may share personnel with oncology or others, and they still provide excellent team-based sickle cell disease care. Co-management is still required with primary care physicians. Again, these physicians are often external to their center. They may share infusion center or day hospital space or have plans for delivering pain management and transfusion therapy with observation units or emergency room physicians. They are often led by a sickle cell specialist, but may have multiple team members, such as other hematologists, medicine, and pediatric providers. And they have all the necessary subspecialists, but may not have them directly as part of their center, but more as a shared resource. We then have specialized sickle cell disease patient-centered medical homes. I like to think of these as one-stop shopping experiences. This is a dedicated clinical staff and space for sickle cell disease that includes both the specialist with excellent team-based care, but also includes a primary care provider within that medical home. So that at any given day, an individual with sickle cell disease could see both their sickle cell specialist as well as a primary care doctor. They must have a care coordinator to be a medical home, and that has to be someone within the four walls. They may or may not include an infusion center or day hospital, but always have to have a plan to provide acute pain management. And this can be a suburban or urban model, and individuals may come from further away or have difficulty coordinating care, which requires a one-stop shop model. It's also important to note that all of the models that I have just described could be hub and spokes models. The hub is the sickle cell center, and the spokes are often primary care physicians. Many of our population live in areas in which they cannot get to a sickle cell center regularly. So while they still need that care, at least every 6 to 12 months, much of their day-to-day care may be managed by a primary care physician or a local hematologist who serve as the spokes. In fact, in some places, these spokes, when led by primary care physicians, can still have infusion areas or shared infusion space to ensure personalized individual pain management. They may also include telehealth or physical outreach clinics to really improve the care within the spokes. And they have a plan for co-management, coordination of care, and emergency management for individuals with sickle cell disease. Regardless, it's most important that all of these providers, all of the sickle cell centers specifically, provide this comprehensive medical practice. That includes disease-modifying therapy, sickle cell disease prevention practice, and iron overload. They have to have available blood transfusion management, a pain management plan and program, and access to family planning and mental health. These are the responsibility of the comprehensive sickle cell center or sickle cell specialist. As you see on here, however, primary care screening and management of other comorbidities is not listed. And for that, we continue to need significant co-management and a plan for co-management and coordination of care. We don't expect individuals who do not have training in sickle cell disease to offer all of the disease-modifying therapy unless they want to, but rather to practice a co-management model of care. In conclusion, we know that many of the affected individuals in the United States who live with sickle cell disease are adults, and that we know our adults, unfortunately, often rely on the emergency department or hospitalization compared to children who are more likely to have a dedicated sickle cell specialist. The issues right now that we are facing is a failed adult sickle cell disease U.S. healthcare system. We are failing, and we have to improve this through co-management to prevent preventable mortality. Most potential clinicians have not been willing or engaged, and so we are looking in other ways and other models to engage primary care physicians to help in the management of individuals with sickle cell disease. This requires an improved delivery structure that includes a transition between pediatric and adult care, a structured co-management where individuals do get primary care as well as sickle cell disease specialty care, or the adult sickle cell disease patient-centered medical home model. And we have to have training and supporting more clinicians as an important way of increasing the access in the workforce for individuals living with sickle cell disease. Finally, there is a huge need for primary care providers in sickle cell disease, and there are so many ways to partner to improve our outcomes. There are some essential elements, but these can differ based on location and planning, with a great variety in the care models in sickle cell. And clearly, our team-based and coordinated care with co-management is key. Thank you all very much.
Thank you, Dr. Cantor. That was a great overview of primary care. Now, our second speaker is Mr. Andre Marcel Harris. He is an individual living with sickle cell disease and is a Bachelor of Social Work student and Reynold E. McNair Scholar at Fayetteville State University. He will share the patient perspective on primary care in sickle cell population. Andre?
Hello? Can you all hear me?
Yes, we can hear you, Andre.
Okay. I just wanted to make sure everyone could hear me. Good afternoon, everyone, and thank you, Marlene, Captain Wong, and everyone who played a hand in inviting me to speak during this webinar today. I count it a privilege and an honor. And I don't have any slides because I wanted this to be more of a communal talk. I didn't want to be so formal. I wanted to have just a conversation from a patient and a patient advocate's perspective. So first off, I'd like to let you all know that, again, I am an individual that lives with sickle cell disease, and I also am an advocate. And so I've seen this disease from not only a patient's perspective, but from a professional perspective. My opinion about primary care would be that I think the issues with patients not being able to, first of all, utilize primary care as we'd like them to is because of the lack of access. And access can be gained primarily through insurance. And so if this population has barriers and hiccups in being able to secure health insurance, adequate health insurance, it is my humble opinion that they will never be able to properly utilize the primary care setting. And the wonderful presentation that Dr. Cantor just gave us was laid out very perfectly, and not to negate anything that she said. However, if a person does not have the proper access to utilize those services, then they won't be able to do so. So I'd like to first off raise that as an issue or a burden that needs to be addressed in the community, that people with sickle cell disease, the majority of those who live with the disease are those who are within or below the federal poverty level guidelines. And so people in this category, in this demographic, historically have had accessibility issues to health insurance and health care. And until we fix those issues at the root, again, as I said before, I don't think we would see any type of improvement. So for me as a patient and an advocate, my recommendation would be, and what I've done in the past to try to help or try to alleviate this burden or ameliorate this issue, is to host kind of like an enrollment or an insurance information session. So I think it's very imperative to educate patients and educate caregivers of minor patients or those who need care about insurance and what they qualify for. Again, if a lot of people are under the federal poverty level, a lot of them may not have stable jobs because they are chronically ill, or a lot of them may not have dependents or spouses or whoever it may be who have a stable job that can offer them coverage to health insurance. And then those who have tried to pursue, Social Security or any type of Medicaid or Medicare services and getting that insurance A lot of them have been denied, and they get discouraged, and they don't appeal or reapply. And so being able to educate this demographic about insurance, I think, is very pivotal to being able to allow them access. And again, I say this from not only an advocate, but from a patient. I was not able to access primary care services because I was not covered under any type of health insurance. And so it was very expensive for me to be able to try to keep appointments if I couldn't pay the copay, or if I couldn't afford any of the costs of care. So that's one point. Excuse me. The other point I'd like to make is, as Dr. Cantor so articulately stated, is that, again, those that live with the disease understand, but again, to really reiterate the issue that sickle cell disease, there's nothing or nowhere in the body that this disease does not affect. Because it is a blood disorder and blood flows to everywhere in our body, there's nowhere that we won't have issues. And so that being said, it's basically inevitable for a sickle cell patient not to have any other issues other than their sickle cell. And many of these issues, unfortunately, are caused by this sickle cell. And if they aren't covered or, I should say, monitored by a competent primary care provider that could know what to monitor for those who specifically have sickle cell, and know how to provide referrals to people who know how to at least competently provide service to those who have sickle cell disease, then they're also at a disadvantage. If there aren't people who are actually monitoring people with the sickle cell in the primary care level for other issues, so that they can get those checked out. And again, not just for sickle cell related things. Of course, it affects our eyesight, our hearing, our vision, all of that. But those who have had strokes, then they also need referrals to PT, occupational therapy. So again, there's a gamut of things that need to be thought of when patients are under a primary care scope. And I feel that there's sometimes, because there aren't many people with sickle cell in the primary care setting, because a lot of sickle cell patients utilize their hematologist as their be-all physician. And again, that's because of a lack of access. And so another thing I'd like to say, just to kind of segue into what I just said, a lot of people have used their hematologist because they did not have access to primary care. I've had cases where I've had patients who were terminated or discharged, or whatever you want to call it, from their primary care provider, simply because their provider was not comfortable providing them with primary care services. And so that poses an issue as well. If there are primary care providers discharging their patients from their service, where is that patient going to go? And so it's very imperative in this conversation to also remind this community that not only do we need competent hematologists, but we need competent people in every specialty, especially primary care, so that they will be comfortable with the referral process to whatever they need, or they'll be comfortable knowing how to give them appropriate service for something that other people may have, like a mammogram, like Dr. Kenner said. Is still needed for those who have sickle cell disease, but of course there may be some other things to keep in mind for that person when you refer them out to someone to give the mammogram. So these are things that we have to educate not only the patient, but the provider for. Excuse me. And then also I'd like to point out, again, like I said, the fact that there needs to be some type of universal widespread education about the overutilization of also the emergency department. Again, sickle cell patients who don't have proper access will utilize the emergency department because they don't have to worry about the immediate copay. They don't have to worry about the premium coming out of their check for the insurance, but they could go and access emergency care. And a lot of people are going to the emergency room for something that should be handled in a primary care setting. And as Dr. Cantor again said, establishing a medical home for that patient is very primary. It's very important. If you have a primary care provider that would be able to manage not only the effects of your sickle cell, but the effects of you just being an adult, getting older, and experiencing life and experiencing health issues in general. We have to have people that understand as patients that I can't pursue the emergency room just because I don't have insurance. We have to find a way to connect them to access so that they can come and not have to be a burden not be burdened, in the emergency room department. We know that most sickle cell patients are very scared and frightened when they go to emergency room departments because of the certain implicit and explicit bias that they encounter. We know that sickle cell patients have been discriminated against. Empirical evidence have showed us that outcomes in the emergency room department on a universal level in this country have been lacking, where sickle cell patients have really experienced terrible healthcare outcomes. However, they continue to go, those that do, because they have no other way to take care of their health. And I think that's something that we really need to address. There have been conferences and meetings that I've attended, and we've demonized patients for the overutilization of the emergency department, and we've demonized patients for inadherence and noncompliance, which are words I think that are very inflammatory, especially in this community. Again, because if we go back and look at the issue at the root, many people in this community are impoverished. They don't have access to transportation. They may not have adequate access to housing. They may not have higher education levels. They may have all of these social determinants of health that are working against them, and they may very well want to be a compliant patient, but the social determinants of health that are in their lives are deterring them as a determinant. They're deterring them from being that adequate or that compliant patient. And so these are all things that we should consider, again, from a patient's perspective. Most providers, I don't want to say most, but there have been many providers that I've encountered where they are good at what they do and they're very educated. However, they've been so far removed from this type of struggle or this type of life of not being able to make ends meet, or not being able to have transportation, or not being able to have money for prescriptions, or having money but having to make the choice between prescriptions and food. And so they're so far removed from that lifestyle that they don't understand when a patient is not meeting their treatment plan or their goals or whatever they put in place. I say all of that to say that this has to be in the conversation when we're talking about primary care, even when we're talking about emergency room care, when we're talking about any type of care for really anybody, but especially people with sickle cell disease. If we want to see more people engage and actually working with primary care providers, then we have to address these issues. And that is at the core of my message, especially here today, and that's the core of my message pretty much anywhere I go, is that we really have to get to the root of a lot of these social issues that affect the biological and medical outcomes of our patients. and I yield back my time.
Thank you. Thank you so much, Andre, for sharing your perspective as an individual living with sickle cell disease. Now, our last speaker is Captain David Wong, who is the work group's chair and medical officer at the Department of Health and Human Services, Office of Minority Health. Now, he will share with us information about the STAMP project. Captain Wong?
Thank you, Marlene, and thank you, Dr. Cantor and Andre, for those excellent presentations. So as Marlene addressed, I'm the chair of the HHS Sickle Cell Disease Work Group, and this is a group that started about a year ago. We now have 60 members from 11 different HHS agencies, all working on sickle cell with different missions, but we're all trying to coordinate our activities and also come up with new innovative ideas that can help improve the lives of individuals living with sickle cell disease. Many of you may have met our leader, Admiral Brett Gerard, who's our current Assistant Secretary for Health. He's really the driver for this work group. He's an incredible sickle cell disease champion and advocate. And when we had discussions with him about a year ago, one of the 2 or 3 areas that he really wanted to make an impact on was this lack of access to care, particularly for adults with sickle cell disease. And so the STAMP program that I'm going to talk about is really our effort to try to help address that. Now, I also just want to reemphasize some of the points that Dr. Cantor and Andre just made, that at the federal government level, we also are very aware that sickle cell patients need to have, providers, both sickle cell experts as well as experts in the primary care aspects in order to really get the high quality care that all sickle cell patients deserve. And so what we're trying to do now with the STAMP program is build off an existing program at the Health Resources and Services Administration, also called HRSA. That's one of the HHS agencies that works a lot on clinical services for sickle cell disease. And they have an existing program called the Sickle Cell Disease Treatment Demonstration Program, and that's been around since 2004. And what we're trying to do is build off that existing program that Dr. Cantor is part of, where they do a lot of education of providers about sickle cell disease. And initially, 15 years ago, that program attempted to train primary care providers on basics of sickle cell care. And what actually happened from that experience is that it was very difficult for Dr. Cantor and other hematologists to get primary care providers to attend their training programs. And what has happened over time now is that the HRSA program has now become a community and a network where hematologists can work with other hematologists and kind of talk about challenging cases and learn about how to take better care of patients with sickle cell disease. However, that original primary mission of reaching out to primary care providers has been lost a little bit, and we wanted to try to resurrect that with the STAMP program. And so what we're doing with this program is not just providing training. I want to make sure that with the models that Dr. Cantor talked about is, yes, we'll be providing some education. I'll talk about that to you later and about how that will be delivered. But we also want to provide an opportunity where primary care providers that participate in these trainings can then provide and access co-management support from hematologists. So if a primary care provider wants to start taking care of an individual with sickle cell disease, they will have additional resources from hematologists to help them to do that. And so I'm really excited to announce that STAMP is actually launching today on the website in terms of recruitment and information that we will be sharing with the public and providers about this program. And this will be a 6-month series of trainings that are targeted just for primary care providers. And these will start in January. The first one is actually on January 8th, 2020, and there'll be 2 sessions per month that run through June 2020. And these are going to cover different topics that we think are pretty basic, that will be of interest to primary care providers, help them understand the needs and complications of the disease of their patients, and also how they can communicate and co-manage with hematologists. So some of the topics that are already on the docket include hydroxyurea, which is a disease-modifying therapy that can be very beneficial for decreasing pain crises, decreasing emergency department visits and hospitalizations. transfusions in sickle cell patients, and also how to manage uncomplicated headache in sickle cell patients. Now, the trainings are going to be delivered through a platform that's called Project ECHO. And Project ECHO started in 2003 in New Mexico. And the idea was there was a GI doctor who was a liver specialist named Dr. Aurora who got frustrated because he could only take care of so many hepatitis patients, the ones that came to see him. Yet he knew that New Mexico is a very large state, had a lot of hepatitis patients that were in other parts of the state that he could not easily reach. They could not easily come to Albuquerque where he was based. And so he developed a platform that is now called Project ECHO, where essentially it's like a tele-mentoring session where primary care doctors will present some of their cases about hepatitis C. And then he, as the specialist, can give a brief presentation on that topic. And then as he hears about that case presentation, there's a rich discussion and a rich mentoring process that happens where the primary care providers learn about what would Dr. Aurora do in terms of taking care of that patient. These are some other aspects you should consider. These are some lab tests that you might want to run the next time you see a patient like this. So over time, as the primary care doctors attend more and more of these sessions, they start to learn more from Dr. Aurora. They become specialists of their sorts in terms of some of the more basic aspects of the disease. And it serves as a multiplier effect for the hepatitis or sickle cell specialists to send their message and their reach to other parts of the country. And so you can see in this cartoon on the right where if the model is just one specialist for one patient, it becomes a very tedious one-on-one process. You can only do so much. But through the ECHO platform, which is what we're trying to do with STAMP, is take a team of sickle cell experts, provide an opportunity for not just education, but mentorship and one-on-one kind of mentorship through this tele-ECHO platform. And then those providers can go out into the communities and have high impact and reach many sickle cell patients that maybe currently are not having good access to care. Now, one of the challenges that we're facing when we started to think about the STAMP program, and this has been in the making for about 6 months, was how do we find those willing sickle cell primary care providers, as Dr. Cantor illustrated in one of her slides? Well, the solution is really not to train all the primary care providers. And just to give you an example of some of the numbers, if you look at the number of the primary care workforce in the United States, we have about 300,000 primary care providers if you look at physicians, nurse practitioners, and physician assistants. So that's essentially 3 times the population of the sickle cell population. And so really we're not trying to reach everyone with education. What we really want to do is try to find those targeted providers who are maybe living in areas where there are a lot of African Americans or Hispanics who might have sickle cell disease, or they're living in places where there are plenty of adult hematologists, but there's such large places like, say, New York City, where those adult hematologists cannot meet the full need. And so what we've done as a group, as our HHS collective of federal agencies, is we've developed a strategy. How do we find, of those 300,000 primary care providers, those that are most willing and interested in taking care of patients with sickle cell disease? So we came up with a strategy. I'm not going to go into the details all here, but there's some geographic ones. We're looking at top 10 cities for African American population and Hispanics. We're also looking at medium-sized cities, or mid-sized cities as we call it. And these are cities that have population of 250 to 500,000 people. They're pretty big places, but they're not places like New York or Baltimore that are much larger, that have academic centers. These places might just have community hospitals, and they might not have adult hematologists. And yet, because their size, they may have a sizable number of sickle cell patients, and where are they going for care? Maybe the primary care providers in these mid-sized cities are ones that would be really hungry for information about sickle cell disease. We're also looking at facilities that we think would be right for this effort. Federally qualified health centers, which are really safety net facilities, student health clinics at HBCUs, historically black colleges and universities. And also, of course, we want to work with many of you on the phone as far as any primary care providers that you know of that might be interested in STAMP. Please share this information with them. So I just want to take a few minutes to talk about a couple just real examples of how we work together with Dr. Cantor and Andre, just in terms of trying to reach out for STAMP. So as we were formulating STAMP, I reached out to maybe 15 different HBCU student health clinics. And when we think about student health clinics, we don't usually think of them as taking care of sickle cell disease. When I was in college, that's where people went for birth control, if they sprained their ankle. If you had something more serious, you certainly wouldn't go there. But knowing that there's this access to care issue, maybe there is a role for HBCU student health clinics for caring for individuals with sickle cell disease. And so of the 15 HBCUs I contacted, only about 2 or 3 reached back to me and expressed interest in learning more about this pilot. And one of them was Alabama A&M University, which is in Huntsville, Alabama. You know, Dr. Cantor lives in Birmingham, which is just a couple hours away. And Alabama A&M, you know, expressed interest, and they pulled their physicians and their providers. They have 2 physicians and 2 nurse practitioners, and they were really interested in learning what they could do. And so together we worked with Dr. Cantor. She actually came up to Huntsville to give a lecture, and we tried to set up a meeting for her to meet with some of the staff at Alabama A&M University. And as it turns out, you know, the lead clinic manager who was really leading this effort, he took another job, you know, just a couple weeks before that site visit. And so I'm going to re-engage with this clinic and see, you know, what they would do and try to see if some of their providers can participate in STAMP. Now, Fayetteville, North Carolina is another medium-sized city on our list also, and it's also where Andre Harris lives, who just spoke. And so knowing that and having met Andre Harris, because he was an intern at the Office of Minority Health over the summer, is we started to think, okay, Andre, as a individual living with sickle cell disease, knowing the providers that are in Fayetteville, can you help us find providers in Fayetteville, North Carolina, who might be interested in STAMP? And now, Fayetteville is an area that does not have any adult hematologists. Previously in the past, maybe 10 years ago, Duke University was sending hematologists down to Fayetteville, but just recently they restarted their adult satellite clinic on September 11th. And this is a bi-monthly clinic, and Andre actually shared with me that he actually attended that first clinic, and he's planning to use this clinic for his care. So there are some options, but certainly because of the size of Fayetteville, we think that there may be, you know, the need, of course, for primary care providers to provide that additional level of care that's needed. So final thoughts, I really just want to emphasize, you know, that, you know, a lot of what we're doing hinges on finding those primary care providers who are motivated and willing to care for patients. Where are they? Now, if we can find them, we think that STAMP is really going to add a lot to their lives, their professional lives, particularly in terms of learning more about sickle cell disease, providing them with the confidence to take care of patients who might have more complications or more challenges than some of their other patients. And they'll be part of this community. They can participate in these tele-mentoring sessions with Dr. Cantor and other adult hematologists, and they can get access to that co-management support. And that might be what is scaring primary care providers from taking on sickle cell patients, is that they don't feel like they have the support. What if they have a serious complication, let's say acute chest syndrome or another complication? You know, they need to have that backup and from the hematologist to really help them and to feel like they can take care of these patients together as a team. I want to acknowledge many folks from the different agencies that have been helping with getting STAMP off the ground. Like I said, this has been a 6-month effort, and we're so excited that the website just went live today, and the link is there on the right of the slide. And we ask that all of you to take a look at this link, and you'll learn a little bit more details about STAMP, and certainly share it with your primary care providers and colleagues so we can get good attendance and interest and start to really make a difference in terms of providing the high-quality care that we want all sickle cell patients to get. And with that, I'll hand it back over to Marlene.
I just want to also acknowledge our stakeholders engagement committee who actually worked diligently to putting this webinar together. At this time, we're going to move on to our question and answer session which Giovanni Spinner will be leading.
All right, thank you, Marlene. Our first question goes to Dr. Cantor. Is there a list available that delineates which hospitals and medical centers fall into the various models?
That's a great question. We are actually working on developing an article that outlines all of the different models, and then a list as well that gives contact information. So hopefully we will have that together in the very near future.
Thank you. The next question is also for you, Dr. Cantor. Would you be able to elaborate further on your experience using telemedicine and where it has worked best?
Absolutely. I had a great experience and actually continue to have a great experience in using telemedicine. A lot of my telemedicine work was all undertaken when I was in South Carolina. I was at MUSC, and we developed a statewide network with a hub and spokes model where the hub was in Charleston, but we had spokes in Georgetown, South Carolina, Beaufort, South Carolina, and Columbia, South Carolina. All of those were connected by telemedicine, and some of them were on an as-need basis. So my patients, for example, who were seen in Columbia, they only needed to be seen by telemedicine during an acute problem because they actually often came to me every 3 to 6 months, but they used their Columbia-based infusion center, and they saw nurse practitioners who were also under me. In Beaufort, South Carolina, we actually continue to operate a medical care clinic there where we have a very small population of about 45 individuals who are seen by a nurse practitioner, and I oversee all of that by telemedicine. I also do some outreach appointments every 3 months where I continue to see patients there. But anything else that's done in between those 3 months is all done by telemedicine. Finally, I had 2 different clinics within the Georgetown setting, and in Georgetown it also worked very well. We saw kids and adults in the same clinical setting through telemedicine. And I think in all of these circumstances what made it work best is that I had met these patients at least once in person, if not more than that. And it's much easier, I think, to establish rapport in person. And then when we see each other via telemedicine, it's like seeing a friend on FaceTime. So it's really very effective. It works out very well. The experience on both sides, I think, was everybody really enjoyed it, and it continues to be an effective model.
Thank you. And before I move on to the next question, I want to encourage anyone that has a question to please type it in the Q&A box. Our next question is for Dr. Wong. Is the STAMP session available to health plan case managers?
Yes, excellent question. So the STAMP sessions, as we've kind of formulated them now, are really designed primarily for those primary care providers that are making those clinical decisions. That being said, we realize that there's a team-based approach that's needed for sickle cell. It's not just primary care provider and hematologists, but it's also social workers, psychologists, community health workers, et cetera. And so I don't think that we're going to turn away anyone who wants to just learn about, sickle cell care from the primary care provider perspective, as long as they're team members of that primary care provider team, but as long as they know that the focus is really going to be on those clinical decision-making aspects.
Dr. Wong, this is Dr. Cantor. Let me just add to that we have had great experience with our health payer case managers on our regular echoes that we do, and there are echoes throughout the entire region. I will make sure you have all that information because anyone is welcome to join those. We use the regional approach because obviously if you have a client that you feel needs to see a specialist that may not have that care, we can more aptly help you through the region. But all of those healthcare managers and providers are welcome to join our regular echoes, and we'd be happy to get that information out.
Thank you, Dr. Cantor. And just for clarity, so the regular echoes Dr. Cantor is referring to are the echoes that the HRSA Sickle Cell Disease Treatment Demonstration Program currently has, and they do those in 5 different regions at many different sites, sometimes within each region. And the STAMP program is another echo session within that structure, but it's going to be a national program, and it's focusing on primary care. But certainly we welcome, just as Dr. Cantor said, Any member of the team that wants to learn more about sickle cell, please join.
All right, and finally, there was a question about if we can get copies of this presentation. I do believe we'll be able to make the presentation and the recording available after the webinar ends today. Within the next few days, we'll be able to have those posted online. And I am not seeing any additional questions in the chat box. So I want to thank each of our presenters today for sharing your perspectives on primary care as it relates to treating patients with sickle cell disease. I also want to acknowledge the hard work of all of our working group members. I'm sure many of them are on the line today listening in to the presentation as well. And on behalf of the Department of Health and Human Services, Sickle Cell Disease Stakeholder Working Group, and the members and the co-chairs, I want to thank all of our speakers again. I want to thank all of our participants for taking time out today to attend today's webinar. And I really hope that you've had an opportunity to learn the importance of utilizing the primary care setting to manage medical care for individuals living with sickle cell disease. And with that, I want to thank everyone for attending today, and that concludes our webinar.
Have a
This
great
does conclude
afternoon.
today's conference. Thank you all for participating. You may now disconnect.
Okay, thank you.